Today topic is obesity. It is a non-communicable disease. Obesity means overweight. Obesity is a abnormal or excessive fat accumulation that presents a risk to health. Obesity may be defined as an abnormal growth of the adipose tissue due to an enlargement of fat cell size or an increase in fat cell number or a combination of both. Obesity is often expressed in terms of BMI, that is, overweight is usually due to obesity but can arise from other causes such as abnormal muscle development or fluid retention. The distribution of fat induced by the weight gain affects the risk associated with obesity and the kind of disease that results. It is useful, therefore, to be able to distinguish between those at increased risk as a result of abdominal fat distribution or android obesity. Now, what is the history of obesity? The age of onset of overweight. The dietary history should include. Dietary history means identification of the caretakers who feed the child, identification of foods high in calories and low in nutritional value that can be reduced, eliminated or replaced. As example, we are talking about juice and soda. Assessment of eating patterns, that is timing, content and location of meals and snacks. Third history of obesity is the activity history should include. Means assessment of after school and weekend activities, assessment of screen time, that is television, videotapes and DVDs and video games. History includes safety of parks and neighborhoods and availability of playground equipment. Now, what is the prevalence of obesity? Obesity is perhaps the most prevalent form of malnutrition. As a chronic disease prevalent in both developed and developing countries and affecting children as well as adults. It is now so common that it is replacing the more traditional public health concerns, including undernutrition. It is one of the most significant contributors to ill health. Obesity is a key risk factor in natural history of other chronic and non-communicable disease. The typical time sequence of emergence of chronic diseases following the increased prevalence of obesity is important in public health planning. Now, what is the classification of obesity? Obesity is a medical condition in which excess body fat has accumulated to the extent that it may have an adverse effect on health. It is defined by body mass index and further evaluated in terms of fat distribution via the waist-hip ratio and total cardiovascular risk factor. BMI is closely related to both percentage body fat and total body fat. In children, a healthy weight varies with age and sex. Obesity in children and adolescents is defined not an absolute number but in relation to a historical normal group, such that obesity is a BMI greater than the 95th percentile. The reference data on which these percentiles were based date from 1963 to 1994 and thus have not been affected by the recent increases in weight. BMI is defined as the subject weight divided by the square of their height is calculated as follows. Now, obesity is an epidemiological disease in global history. Globally, an estimation 170 million children, that is less than 18 years, are estimated to be overweight. Almost one-third of children and adolescents in the United States are either overweight or obese. The prevalence of obesity among children and adolescents tripled from the late 1970s to 2000. Now, what is the effects on health? Excessive body weight is associated with various diseases and conditions, particularly cardiovascular diseases, diabetes mellitus type 2, obstructive sleep apnea, certain types of cancer, osteoarthritis, and asthma. As a result, obesity has been found to reduce life expectancy. Definition of BMI. BMI is value derived from the mass, weight, and height of a person. The BMI is defined as the body mass divided by the square of the body height and universally expressed in unit of kg bar by m square. M square means the weight, the height in meters, resulting from mass in kilograms and height in meters. Now, what is the assessment of obesity? The assessment of obesity is four, that is body weight, skin fold thickness, waist circumference of waist hip ratio and others. Now, what is body weight? Body weight through an accurate measures of excess fat is a widely used index. In epidemiological studies, it is conventional to accept the standard deviation from the median weight for height as a cutoff point for obesity. The body mass index is also widely used for assessment of obesity. Now, what is skin fold of thickness? A large proportion of total body fat is located just under the skin, since it is most accessible of skin fold thickness. It is rapid and non-invasive method for assessing body fat. Third is waist circumference and waist hip ratio, that is WHR. Waist circumference is measured at the midpoint between the lower border of the rib cage and the iliac chest. It is a convenient and simple measurement that is unrelated to height, correlates closely with BMI and WHR, is an approximately index of intra-abdominal fat mass and total body fat. Changes in waist circumference reflect changes in the chronic diseases. Next, others. In addition to the above, three well-established and more accurate measurements are used for the estimation of body fat. They are measurement of total body water, of total body potassium, and of body density. The techniques involved are purposely for epidemiological studies. These all are the BMI. Next, epidemiological determinants. What are the epidemiological determinants of obesity? First factor is age. Obesity can occur at any age and generally increases with age. Infants with excessive weight gain have increased incidence of obesity in later life. It has been well established that most adipose cells are formed early in life, and the obese infant lays down for more of these cells than the normal infant. Hyperplastic obesity in adults is extremely difficult to treat with conventional methods. Next is sex. Women generally have higher rate of obesity than men, although men have a higher rate of overweight. On the other hand, in many developing countries, constituted pregnancies at short intervals are often associated with weight loss rather than weight gain. Next is genetic factors. There is a genetic component in the etiology of obesity. Twin studies have shown a close correlation between the weights of identical twins. The profile of fat distribution is also characterized by a significant heritability level of the order of about 50% of the total human variation. Next is physical inactivity. Physical inactivity is most common in our life. There is a convincing evidence that regular physical activity is protective against unhealthy weight gain. Whereas sedentary lifestyle, particularly sedentary occupation and inactive recreation such as watching television, promote it. Physical activity and physical fitness are important modifiers of mortality and morbidity related to reduction in activity without the compensated decrease in habitual energies. Physical inactivity may cause obesity, which is termed restrict activity. Next is socio-economic status. The relationship of obesity to social class has been studied in some detail. There is a clear inverse relationship between socio-economic status and obesity within some affluent countries. However, obesity has been found to be more prevalent in the lower socio-economic groups. Eating habits. Example, eating in between meal preference to sweet, redefined foods and fats are established very early in life. The composition of the diet, the periodicity with which it is eaten, and the amount of energy containing more energy than needed may lead to prolonged postprandial hyperlipidemia and to deposition of triglycerides in the adipose tissue, resulting in obesity. Nowadays, television and print media is playing an important role in producing obesity by heavy advertisement of fast food outlets of energy dense, micronutrients poor food and beverages. The consumer demand by itself may be influenced by advertising, marketing, culture, fashion, and convenience. It has been calculated that a child whose energy requirement is 2000 kilocalorie per day who consumes 100 kilocalorie a day extra will gain about 5 kg a year. Next is psychosocial factors. Psychosocial factors are deeply involved in the etiology of obesity. Psychosocial factors means, as an example, we are talking about emotional disturbances. Means if a human being is psychologically disturbed and psychologically he is in depression, anxiety, frustration or loneliness, it is a very much effect for her or for their life. It is in adult life. Excessive obese individuals are usually withdrawn, self-conscious, lonely and secret eaters. Next is familial tendency. Obesity frequently runs in families, but this is not necessarily explained solely by influence of genes. Next is endocrine factors. This may be involved in occasional case, that is, as example, Cushing syndrome, growth hormone deficiency. Next, epidemiological determinants is alcohol. A recent review of studies concluded that the relationship between alcohol consumption and adiposity was generally positive for men and negative for women. Education. In most affluent societies, there is an inverse relationship between educational level and prevalence of overweight. Next is smoking. Reports that use of tobacco lowers body weight began to appear more than 100 years ago, but detailed studies have been reported only during the past 10 years or so. Next is ethnicity. Ethnic groups in many industrialized countries appear to be especially susceptible to the development of obesity and its complication. Evidence suggests that this may be due to a genetic predisposition to obesity that only become apparent when such groups are exposed to a more affluent lifestyle. Drugs, use of certain drugs, as example, corticosteroids, contraceptives, insulin, adrenergic blockers, etc., can promote weight gain. Dietary recommendation: avoiding the consumption of calorie dense, nutrient food products, example sweetened beverage, sports drinks, fruit drinks, sweets, most fast food, and calorie dense snacks. The ideal beverage for children at all meals and during the day is water. Reducing saturated dietary fat intake for children older than 2 years of age. Prevention and control. Prevention and control. First is, weight control is widely defined as approaches to maintaining weight within the healthy. Prevention of obesity should begin in early childhood. Obesity is harder to treat in adults than it is in children. The control of obesity centers around weight reduction. This can be achieved by dietary changes, increased physical activity, and a combination of both. Now, dietary changes. The following dietary principles apply both to prevention and treatment. The proportion of energy dense foods such as simple carbohydrates and fats should be reduced. The fiber contained in the diet should be increased through the consumption of common unrefined foods. Adequate level of essential nutrients in the low energy diet. The most basic consideration is that the food energy intake should not be greater than what is necessary for energy expenditure. It requires modification of the patient's behavior and strong motivation to lose weight and maintain ideal weight. Next is increased physical activity. This is an important part of weight reducing program. Regular physical exercise is a key to an increased energy expenditure. Means you have to increase the daily workout for the control of your weight. Others, appetite suppressing drugs have been tried in the control of obesity. They are generally inadequate to produce massive weight loss in severely obese patients. Surgical treatment, eating of solid food surgical treatment, that is example gastric bypass, gastroplasty, jaw wiring, to eliminate the eating of solid food have all been tried to limited success. Health education has an important role to play in teaching the people how to reduce overweight and prevent obesity. A fruitful approach will be identify those children who are in risk of become obese and find way of preventing it. Prevention of obesity, breastfeeding. Breastfeeding is recommended for a minimum of 6 months. Breastfeeding in infancy is associated with a decreased incidence of overweight and obesity in childhood. Conclusion: overweight and obesity among children in Saudi Arabia should be considered a serious public health problem. The prevalence is on the rise. Health institutes, parents and schools should have an interactive and integral role for the prevention of such outcomes. Thank you.